I'm going to say we had an oxygen and we had mixed bag and we had the woods. How is that? Welcome to the Inside Track, a series from the Global Health Matters podcast. In this series, we step inside the conversations shaping global health, the debates, the dilemmas, and the decisions that don't always make the headlines. Each episode features two recurring expert pundits, Kyobutungi and Ricardo Baptista Leite, offering informed, independent analysis grounded in lived experience. Consider this your invitation to the inside. Hi there, and welcome back to the Inside Track. Well, here we are again. How are you, Ricardo? How are you, Catherine?
Very well, thank you, Garry.
I'm very well, thank you.
Okay, no, you're not convinced, but you have some big news, Catherine. You have some big news. You are now on the Accra Reset panel or something like that. Tell me more.
Yes, I was invited to join the high-level panel for the Accra Reset, just like that, which is great.
It's great, yeah. I mean, I wasn't sure where that whole thing was going. Do you know why they call themselves economic and health sovereignty together? Any reason why they added economic there?
I guess because I think it's a politically driven process. And I think if you're the president of Ghana and you want to talk about sovereignty, I think it's hard to isolate health outside the other sovereignty issues that maybe Africans want. So, yeah, I think that's how it ended up being both.
Okay, well, that's great. So we know who to call next time we want to know everything about the Accra Reset, Catherine.
Yeah,
yes,
congratulations.
We just had our first meeting, so I'm waiting to see what happens.
And actually, we were talking about the Accra Reset, I think, in our last episode. So very, very timely. And I couldn't agree more with Garry. We're very fortunate to have you there. Wishing you the best of luck.
Thank you. Maybe somebody listened to our episode and said, oh, I don't know.
Must have been that, right? All the magic happens here, right? And that's good. That's good. And maybe we'll bring this back for future episodes and see where things are going. So again, great. Congratulations, Catherine. And Ricardo, you had an eventful weekend, I hear. Any chance to convince your family to listen to Inside Track yet?
Actually, so what Garry is referring to is that once a year, I would go with my wife. This year, we actually took our my eldest stepson, who also joined us, to a pilgrimage to Fatima in Portugal. And so it was almost 100 kilometers over 3 days that we walked. I found out during that journey that they are actually listening to the podcast, although they had not told me. And so, you see, that's a divine revelation there. And so I was happy to hear that they liked it very much.
Okay, great. Well, I hope you're not too tired for our discussion. And both of you, let's get started again on our topic of the day. I picked... are we ready for the next pandemic? And that's something been obviously on top of a lot of governments' mind. Well, I hope. And in terms of preparedness after COVID, and we said never again. And maybe are we there? So I just wanted to start by asking from what you've seen and we've been to. Locations you are in, or countries you've visited, or you worked in, or things you've heard about. Do you think we are better prepared today in 2026 for a pandemic-like event that might happen anytime, basically?
Ricardo, you can go first.
Well, I would argue that in a way we are better informed today after what we lived, particularly through COVID. We are better informed, but not uniformly better prepared. That's how I would state it. What I mean by this is, of course, we have the pandemic agreement negotiations that are happening. We had an initial draft approved last year, but we all know that there's a bottleneck on one hand with the pathogens access and benefit sharing system annex, the so-called PABS annex, which is a problem to be solved. And it doesn't seem like the member states are willing to do so as of yet. And so in reality, the pandemic agreement isn't more than good intentions at this point. There's another very serious bottleneck called the United States of America, which, as we know, is not truly part of the process, having excluded themselves from the World Health Organization. And so this, of course, raises tremendous concern for all of us who went through the process of COVID. To see where we were back in 2020, end of 2019 until now, I think inevitably there were many gains. When we think about detection or sequencing or scientific speed, even political awareness towards the topic, certainly I would say, as I was saying at the beginning, we're all better informed. I would even argue that many global health organizations have change processes and become more sensitized on how to react in these conditions. But most of these organizations depend on funding, and the funding, I would say, is not where it should be. Actually, we're seeing a decrease in funding from across the board. It's not just the U.S. And so, you don't want to, after what we went through, and now that there's a greater knowledge and consciousness towards the risks and potential impact of a pandemic threat, knowledge is not enough. You need to have the resources and the agreements to move forward. I would add to all of this that the pandemic during COVID, a tremendous sense of inequity grew globally in terms of access to the benefits of many of the scientific advancements that were achieved, from the most simple ones to the most advanced ones. And that equity issue, especially without solving the PABS issue in the pandemic agreement negotiation, becomes a true problem. And therefore, I'm hoping that moving forward, the member states that are still part of the process do find some form of agreement. On a very personal note, I'm a strong believer that it would be better to work with a coalition of the willing, even if it's 40, 50, 60 countries that are willing to seriously address these challenges, even if we cannot get a full global consensus. Because then I believe that the benefits that will come out of that are better than not having anything. And others, as future threats, which are inevitable, appear, they will see the benefits of being part of such a coalition. And so I would say there's a mix of some deep concern, but also some hope that we may find a path forward, not the ideal path. One last thing just to say, because it's something that resonated a lot with me during the COVID pandemic, was a lot of, because then I deep dive a bit more at the time into the history of pandemics, and most particularly the so-called Spanish flu in the beginning of the 20th century. And it's interesting to see that many of the lessons learned were lost because then we didn't have a pandemic over a couple generations that was of that dimension until we hit COVID. My fear is that if another generation passes, some of the advantages that came out of understanding and being better informed from this pandemic, if they're not institutionalized within governments, within processes, within international organizations, within civil society, that we may take a step back as humanity and lose some of the advantages of being better informed. And so we do need to be proactive to be better prepared. It's not something that will happen naturally. It will depend on leadership. And so I believe we have upcoming elections for the new the new director general of the World Health Organization, I believe that whoever stands for that role has a huge responsibility to say what they're coming for in terms of how they stand on this issue and how they're going to ensure that the world will be better prepared in terms of future global health threats.
Okay, well, Ricardo covered the whole world in his first intervention, so we've left nothing to talk about. No, I'm just joking. But Catherine, I want to hear from you.
Oh, there's still a lot to talk about, actually. I think Ricardo has covered what I'd call the global, so those things which happen in those big capitals of the world, and I think I would totally agree that it's a mixed bag. I think science gave us a head start, and that head start has kept on increasing. I think there's much more advances in terms of the technology. Maybe it would even be faster to come up with a vaccine than it was last time. So that's a good thing. And several things have happened. The institutions which were involved, maybe to a great degree, have learned a lot. They made mistakes. Maybe they want to make the same mistakes again. So they are good things. But the question is, when we say, are we better prepared? If we are at 20, are we at 80? No, we're probably at maybe 35, which is better than 20, but not maybe what is required to get us to, to prevent all the impacts of something like a pandemic. But I want to focus more on what's on the ground. In some, for instance, more specifically on the African continent, because one of the issues that came out clearly was the inequity that Ricardo talked about in terms of access to technologies. And of course, the most important technology was vaccines. And as a result, since the pandemic ended, there was several initiatives to improve vaccine manufacturing capacity on the continent. And of course, led by the African Union with input from the Africa CDC, there was a political process where African governments sat down and said, okay, this is completely unacceptable, and we're going to see how we can engineer the ecosystem so that by 2030 we have greater sufficiency when it comes to vaccine manufacturing capacity. So they started several things, and there's a whole strategy that was launched. And one of the things in practical terms which has happened was to try to build infrastructure that would make it faster to transfer messenger RNA technology to the African continent. So things have been happening on that front. There was a hub set up in South Africa, through WHO. And then there are several other parts of that whole ecosystem on the continent. There's a hub a facility in Rwanda. And then this is supposed to be like a hub with spokes in Senegal, in Kenya, in Egypt, and all that. So those are happening. There's funding, infrastructure is being put up. So that's the good side, that if there was a messenger RNA vaccine, with all these other processes happening, it might be faster to manufacture it for the African continent, even though how fast these facilities would be activated to start manufacturing, that's a different thing. But at least they're there. There's some kind of infrastructure which is being set up for doing that. I think the bigger issue is the health system, the healthcare system. And I'll talk about two parts. One, during the COVID-19 pandemic, lots and lots of countries set up ICU units, like overnight. That was one of the biggest areas where investments were made. So they set up ICU units, bought beds and all these things which are required. But then recent evidence has shown that most of those ICU facilities are not functional for different reasons. It was a crisis, so you could set up beds, set up oxygen and all these things. But now what is required to keep them running so that they are available for the general public right now, those investments didn't happen. So several ICU units are not functional, even though the beds are there, but because there are other things which are missing, the staff and everything else that is required. So that's one big thing. We made progress and we've gone back. The second big issue is medical oxygen, which was a huge factor in the care of COVID-19 patients. And again, huge investments in oxygen production plants. But recent studies again show that most of these plants are not functional. Some of them function for as short as 2 weeks, some function for 3 months, and many of them were never actually functional. So there's some small bright spots across the continent. I think Ethiopia tripled its ICU capacity. Uganda went back and forth, so they are slightly better than where they were pre-COVID, but they don't have the capacity to ICU capacity that is required. If something was similar like COVID. Kenya and Uganda still suffering with the oxygen thing. They invested a lot, but most of those plants are not functional. I think Malawi is the one that had an oxygen plant that is still functional and perhaps even beyond capacity of what was required during COVID. So still a mixed bag, prepared in some ways, but not in all ways.
Okay, but Catherine, and Ricardo mentioned the agreement, but Catherine, there is this international health regulations, which is basically it's not a treaty, but it's for those who are members of WHO. You can opt out, but by being a member of WHO, you are following the regulations, and they updated them in 2024, basically after the COVID experience. There are other things like surveillance, labs, risk communication, you name it. How about those parts? I mean, you've covered some of the system parts, which is extremely important. I've looked at some of the numbers, and I feel from what I heard that it's not like that part is even either. But what's been your observation when it comes to those parts of the system?
I think those parts of the system, if I could, I don't know what to call it, maybe the software of the system, those parts that have to do with how governments or how countries work with each other at that level, frameworks, agreements, those things, I think there's been a lot of progress. But the question is, some of those things existed before, and those were not the problem. They were problematic, but fixing those without fixing the other things, the ecosystem and infrastructure, without fixing the politics, because the reason why there was these huge vaccine inequities wasn't purely a supply issue, it was a political issue. So those things may have progressed. That's why I said we've moved perhaps from 20 to 35%. We're not where we were, but the other pieces need to be in place for us to feel like, if maybe something similar came in 6 months, we'd have a handle over it. So it might still take us, instead of 2 years, it might take us 1.5 years, which is great, but it's not. It should take us 6 months, perhaps. 1.5 years is better than 2, but it's still not great because of those other things.
Mm-hmm. Ricardo, do you want to add anything?
Well, yeah, I mean, I agree with Catherine. And looking at the revised international health regulations, at least the countries that are willing to be part of that process, that were willing to be part of that process, it does bring, I would say it does bring some more coordination. And, it created the concept of a pandemic emergency. It strengthens some of the legal frameworks that are necessary in the context of preparedness and implementation. But there are some very significant issues that are basically a reflection of what Catherine was mentioning that are not solved. Particularly, the new revised regulations don't fix the core distributive injustice that we saw during COVID. So we are going back to the equity issue. It's far from being solved. Namely, the fact that the idea of countries sharing pathogens or data will many times be the ones last in line for diagnostics, therapeutics, and vaccines. So the incentives, I would say, continue not to be aligned, and so I guess we can say that the revised international health regulations improve the signal and coordination side of preparedness, but the PABS issue that we were discussing is really about whether the share and benefit side will be credible. And so basically, are we willing to, as a globe, among all the different member states, are we truly willing to go from good intentions to something that actually can be truly effective in a time of crisis, in a time of a pandemic threat that puts us all at risk? But I also want to reinforce what Catherine mentioned around health systems and health system resilience. This is something I feel as I as I personally travel and meet with several leaders of health systems around the world, I feel that there was a positive evolution. There was a greater understanding that the more frail you are in terms of your baseline health system, the more vulnerable you are when a crisis hits. Understanding that concept of resilience is absolutely critical. And I think that will actually spill over into discussions into many global health organizations, many of which have been built on a vision focused on vertical approaches on certain disease areas, for example. To address those vertical challenges, we may need to have a wider vision of health system resilience, even if we want to address a specific problem in a health system. So I would say that today, one cannot take on even a very specific area of health without integrating that specific challenge into a greater vision of system and ensuring that the system can stand the stress test, which ultimately is what a pandemic is for health systems. If you fail that test, people lose their lives.
But do you guys think that each country can or is able to actually invest in the same way into all of these systems? I mean, there were these other mechanisms like pandemic fund and other things that were sort of requesting countries who are needing sort of help to apply and get funding to build those parts. Is that also even, or what you've seen is helping, or that is still not sufficient in terms of funding or capacity? What's your observation, Catherine and Ricardo, both of you, if you want to pitch in on this?
I mean, I think that's the whole thing about this being a mixed bag. There are countries which have taken advantage of some of these funding and tried to do things that actually strengthen the underlying health system. But I think the question is, where do you start? Because the things which are obvious, things like oxygen and ICU capacity, those have fallen back to where they were. And I think it goes back to the earlier question of what exists inside countries. And if you have a system that is where already the whole concept of health system strengthening is not something that health systems do, then everything becomes projectized. You have a project to improve oxygen, but then what happens after that? Things fall apart. You have a project to improve ICU capacity, then things fall apart. So when you have these other sort of conceptual things that are not clear, when you think about pandemic preparedness, how do you unpack it? What does it mean? And for people to integrate that into their, sort of strategic health system strengthening, it becomes problematic. So a lot of the pandemic preparedness work is also project-based. It's program-based. It's initiatives and interventions that are time-bound. They are not things which have been sort of fully integrated in health system strengthening. But I think one of the things I would say that Ricardo mentioned is how now what I would call the global health architecture players, the realization that, yes, you can be Gavi and you can invest a lot in vaccination programs, and in 6 months, all your gains can be wiped out because the underlying system was not good. And therefore, how Gavi needs to operate differently to sort of shore up that foundation of health systems. I think that was a positive, and I think that's happening in the way the global health initiatives like Gavi or Global Fund, how they are funding. Now it is okay for countries to say we want to build system things, not treat, not give out medicines or bed nets or things like that. So that's a positive. But again, I think we are better off than we were. But I don't think we're in the place where you can say we are prepared for any eventuality. That is many years away.
Yeah, I think Catherine's right, and thinking about the future even of other organizations like the Global Fund. So these are all organizations that I think are already investing in parts of that resilience health system strengthening component. But how this is going to evolve over time will take very strong and strategic leadership and vision. And quite honestly, it's not an easy task. And also, you need the countries, the member states, the potential beneficiaries who are part of the process first of all, to be part of the process, but also to want to be part of that process and to want to invest in this pathway. You were mentioning, Garry, the pandemic fund and other similar instruments. Even development banks today are providing a lot of funding in this space. But as you know, most of them act upon the request of the governments of the member states. And so nobody's going to force another entity or another government or another country to invest in health system resilience. So there is a tremendous piece of information work that needs to be done, which then raises the political challenge at hand. And I must say, as both of you know, I work a lot with parliamentarians,
right.
And the sensitization existed, of course, during COVID. Politically, it has become almost toxic to talk about pandemics in the political arena right now. This is a problem because politicians, after so many years where health dominated 99.9% of the political discourse during the pandemic, any talk around pandemics or vaccination or all of these topics that are incredibly important now after the pandemic, even more important than during the emergency, I would say, because now is the time to prepare for the next pandemic. Now there's a certain hesitancy to even address this topic because people feel that it will take away votes. It will take away support. And this is a huge challenge because one would think, right, politically, if we have a politician who's advocating for our country to be better prepared in the time of crisis, that they would get the support from the population. But it's the other way around because they say, oh, you're talking about something I don't want to remember as a citizen. I don't want to think about having lost family members and friends and the hardships, the economic impact of what COVID represented for my country, for myself, for my family. And so if it's a topic that politicians are not willing to discuss and debate, it's hard to get them then to prioritize and to move and to put the resources where they're needed. And so, actually, the Unite Parliamentarians Network, we're doing our global summit in August in Manila. We're putting pandemic preparedness as a key topic. And several of the organizations that we were mentioning here, including the Pandemic Fund, will be there precisely because we need those that actually are the budget holders in each country, the parliamentarians, to take the lead. And so when governments may be hesitant, we hope that parliamentarians can be the voice of the people and keep this as an important topic and agenda. And also, even if we do get a pandemic agreement finalized, in many countries, we will have to have some form of ratification process at the national level, and that once again goes through parliaments. If parliamentarians are either unwilling to discuss this topic or uninformed or misinformed, then we will be facing serious problem down the road. And so it's a global effort, and all of us have to be an active part of it. And it's not something that we're going to solve from one day to the next. So I would say it's a systemic change that impacts everyone in this so-called global health space.
Okay, so but help me. Do I now have? I walked into this a bit more positive. I'm thinking we're ended up with a little bit of a pessimistic note. Maybe, I don't know. But will the treaty? Whenever it comes, if it happens, if you want to bet on it, you can mention here if you think it will happen or not. It will. We'll know after this episode airs actually quite quickly where it goes. But will the treaty help with all of those other system issues right away? Or is that sufficient? And you can just maybe react to it and we can close down on this one.
I think from my seat, it's one of those things about the disconnect with what happens in the global space and what happens in reality in countries. There is such a huge disconnect. The treaty will happen. How it's operationalized will vary from country to country, and the front runners will still stay the front runners. So these things help a little bit, but they're not sufficient. And that's because the focus is up there around where all these things are negotiated, create all these mechanisms and frameworks that in the ideal world would cascade to the national level where the actual action happens. But what happens is many times those treaties stay up there. They stay up there. And countries will sign up to them, countries will sign up to all sorts of commitments, and they go back home and they do the things that they do. So the treaty is great. It helps us move forward in one way. But again, I don't think it's sufficient. And we shouldn't look at having the treaty is a good thing, but you shouldn't say, oh, now we're out of the woods, right? Because you have the treaty, because the operationalization on the ground.
Exactly.
Is something else.
Right.
So I think Catherine came up with the title for the episode. We're not out of the woods is clearly a good message here, because it's such a powerful idea that is so true. And whatever the result, either having a treaty or having a half treaty or having nothing, it doesn't matter. At the end, what matters is what we get done on the ground. Of course, a treaty will facilitate that process. It will help everyone who wants to move in the direction of making sure that the world is better prepared to keep people safe, which is what we're talking about at the end of the day, keeping populations safe from potential health threats and making sure that our economies can stay resilient and robust and don't be negatively impacted because of global health threats like we saw during COVID. That's the bottom line. And so all of us, be it academics, be it industry, be it civil society, parliamentarians, politicians, everyone has a responsibility at the national level and at the regional level to continue pushing forward. If we agree on a global framework, that's amazing, because that gives us a common language and to strive on and to build on top of, then adapting to our local realities. But the vast majority of people and organizations and countries actually are supportive of this idea. And we need to build on top of that. So I want to go back to what I said at the beginning, where I believe that ultimately, in the current political context, there will be some players who do not want to be part of this global process. That's okay. Let's work with those who do. We need to focus on the coalition of the willing to make sure that we can continue to progress, to move forward. It's not because of some actors who have stepped away or have decided to not be part of the process that the rest of us should just consider ourselves defeated, knowing that if we act today, we will be ensuring a healthier and safer future for everyone in the future.
Okay.
I hope that made it a bit more positive as we ended this.
Sure. I'm going to say we had an oxygen and we had mixed bag and we had the woods. How is that?
I think that reflects it well.
All right. So next part of our today's episode is the clipping. So our listeners will remember that we pick an article that we'll then discuss quickly to see what's happening with science or other policy and other news. So today's clipping is the article published in carcinogenesis, I guess. And it's the carcinogenicity of e-cigarettes, a qualitative risk assessment by Bernard Stewart et al. From the University of North South Wales in Australia. So we'll keep the link to the article for our listeners. Sadly, it's not open access. Maybe that's a whole other episode we'll have in the future on open access. But I quote from the article that nicotine-based e-cigarettes are likely to be carcinogenic to humans who use them, causing an indeterminate burden of oral cancer and lung cancer. Okay, so discuss.
Maybe I can go first, and I'll just say that I, having been a researcher in non-communicable diseases and have been having a huge focus on risk factor reduction, especially tobacco use, there's a whole community that I'm part of in Kenya, and once in a while they have these campaigns around tobacco, harm reduction. And recently, I think about 3 years ago, they found out that actually some of these e-cigarettes products had been approved in Kenya, without due process. So they launched a whole campaign, sort of decampaigning them. And every time that campaign was put out there, we got pushback from a very well-organized community online that was like, yeah, you're missing the point, because these are supposed to be actually harm reduction, because they are an alternative to, tobacco use. And they had all sorts of research that showed this and that, and how these things were a safer alternative, and therefore when you take them off the market, then you exposed more people to tobacco use, which is like the one that is very harmful. So this paper was quite interesting, seeing like this analysis. And I think for listeners out there, the thing is, how do you determine that something is carcinogenic or maybe is cancer causing? I think that would be like the late term. There are several things which are done. One is to say, does this product, for instance, affect certain parts of the body in certain ways? Because it is known how cancer progresses from a healthy tissue, whether it's in the lungs or what, and how it becomes cancerous. So those things are looked at. Then, of course, they look at animal studies. If you expose them to this product, what happens to these animals? If you do, so all these things are done, and then people come to judgment. So what this study has done is to review, I think, more than 170 papers that have been published since 2017, and looking at all these different aspects, saying, yes, it is likely. And the word likely is used intentionally. It means something. So it's not definite, but it's likely. Now, the problem is, should you wait, if something is likely, should you wait until it is definitely cancer causing before you do something about it? And I think the answer is no, because if you wait, you may need to wait for 15 years for now it to be definite that it's cancer causing. And in that period, you've exposed millions of people to something that has potential to cause cancer. So it's a very interesting paper, and I think it's quite compelling. If you they looked at how these substances change the genes whose expression could lead to cancer. They looked at changes in the tissues in the throat and the lungs. They looked at animal studies. I think in mice there was almost a 10-time fall of mice that got cancer compared to those that didn't get these things. So I think it's quite compelling. The question is, maybe wait for the pushback. Maybe we'll get now new evidence which show that actually they're not as bad as this analysis has shown. But I think it's a very, very, very important study.
Yeah, I appreciate Catherine having framed it this way, because I think this is incredibly important. We have this discussion, especially as we're seeing the younger parts of our population adopting these e-cigarettes and vaping alternatives.
But when you add mint, mango, bubblegum, or vanilla, they seem less dangerous. Flavors are meant to hook you and then keep you addicted.
Don't be fooled. These tactics are by design to addict, not protect.
Based on this marketing campaign, which much of it is also subliminal, to trying to pass on the idea that this is safe, right? Unlike your conventional smoking, this is safe. And that is a false statement that we already knew to be false because of the chemicals, the nicotine, and so forth within these products. But now I think this study reinforces the cancer-causing nature related to the use of these products. This is a huge problem, I would say, that we're facing globally, because industries that develop these kind of vaping technologies and e-cigarettes have been pushing this narrative around harm reduction, as Catherine mentioned. I remember very much at the beginning of the emergence of these products into the market, one big industry asked to meet with me. At the time, I was an elected representative in the National Parliament of Portugal, and they wanted me, because I'm a big advocate for harm reduction drug policies, and they wanted me to voice out my support for this tool to be used as a harm reduction tool for people who are smokers to convert. And for those that are not so familiar with the idea of harm reduction, is you come up to the conclusion that these people will not stop consuming. So you provide them an alternative that is less harmful, ideally mitigating risk towards their health by changing their behavior into an alternative option. And so their theory being that the reason we are so focused on e-cigarettes is because we know that as an industry that this is better than your conventional cigarette. Mind you that many of those developing the e-cigarettes are the same ones developing normal cigarettes. And so basically they don't care, but as long as it contributes to their bottom line. But what I told them was, okay, you want my support to say that this is useful as harm reduction because basically you want smokers of conventional tobacco smoke to convert to your e-cigarettes. I say, okay, I will support you on one condition. The condition being that you will not allow your products to be sold to anyone who is not clearly a smoker today. And so going, just like we do with harm reduction drug policy, we're not giving methadone to people who are not opioid users. And so if you want to use that term of harm reduction, I will support that. I will support that if you use it from a medical scientific perspective, if you're using the term harm reduction seriously. And what they said was, we'll think about it, and I never saw them again because they disappeared. And what that company in particular started selling their products in basically every gas station in Portugal. And that goes to the issue where it's actually much easier to sell these products than it is your conventional tobacco. And so this goes to show that the industry has no concern at all in terms of people's health. These products are built to get into a younger population that was not willing to smoke your old-style tobacco that used to be promoted in the 1940s and 1950s because the consciousness over decades was built that they are harmful for health. And they are now adopting these e-cigarettes and alternatives under the false premise that they are safe. And we know today that they are not safe, beyond the fact that the long-term effects we still do not know, but most probably will even be equally detrimental. And so I think it's extremely important that policies be updated to have the same level of, I would say, of rigorous approach towards these kind of products that we have in terms of conventional tobacco. Because it shocks me also when I go to certain airports, for example, and you know how you have these smoking areas in certain tobacco and in certain airports, and sometimes the smoking area for e-cigarettes. There's a specific area for e-cigarettes and another one for conventional tobacco. And you look into the conventional tobacco lounge, it's full of smoke and everybody looks, kind of grayish or yellowish and it looks horrible. And then you look into this e-cigarette lounge that looks like an Apple store, right? It's all beautiful and they're serving matcha tea or whatever. And they're creating this sense of well-being. And this idea, this false notion that it is a lifestyle choice. And that is incredibly attractive to Gen Z and Gen Zers and to the youth. And it's something that concerns me deeply because it's all based on false messaging. And building on top of this, as the CDC says that apparently e-cigarettes could be potentially a little bit less harmful than your conventional cigarette. And what industry said from there is, no, it's not harmful at all. And so they extrapolated to this false messaging that is grabbing a whole new generation of consumers that will be addicted for life. And that's something that I think as health experts, as scientists, we have the obligation to highlight the potential risks and to highlight the strategies that these industries are using.
Okay, so
maybe if I
yes,
could,
Catherine,
sorry, if I could add in some numbers here, from just to give some perspective. 80% of people who start using e-cigarettes don't quit. 80% don't quit. They instead of getting addicted to tobacco cigarettes, they get addicted to e-cigarettes. So just think about that with this whole young population where these things are being marketed. That's one thing. And then apparently, again, science shows that people who use e-cigarettes are 4 times more likely to start smoking now regular cigarettes than those who don't use e-cigarettes. So 80% don't quit, and then they are 4 times more likely to start smoking cigarettes. And then the other statistic is that in terms of quitting, smoking. Now, if you give it to people who are smoking, nicotine patches, I think about 15% quit in 6 months. And e-cigarettes, it's about 25% in 6 months. If you take it to 1 year, nicotine patches is about 9%, and e-cigarettes is about, I think, 12%. So you're exposing a whole generation of young people to something which is supposed to be safe. And I would totally agree. If they are harm-reducing products, then market them and give them only to people already smoking. But again, 12% stop smoking in a year, that's not as much as you'd think. And compared to nicotine patches, that's like, I don't know. The public health benefit, I think, is doubtful. It's doubtful. And I think this research now shows that
dual use.
Exactly. So this shows that, I think something drastic needs to be done about them.
Okay, so this is what happens at Clipping. Our audience would appreciate an article became such a hot topic for us to discuss. So that was really good. I hope that those listening put all of these things into perspective and now question these various opinions and all of that and put things into perspective. Basically, vaping was sold off as off-ramp from smoking or to quit smoking, but it's becoming a new sort of on-ramp to long-term potential cancer risk. And we probably need some new regulations for this particular product, if not in the same level, but some kind of way to control and bust the myth around them that are floating around. Okay, both thank you for that. So let's go to our last part. And our last section is the kudos section. So I hope you came prepared to give kudos to someone, something that has happened in global health in recent weeks. Catherine, you go first today.
Can I do 2 kudos?
That's fine. Quick, go.
This is not global health, but I want to give kudos to Pope Leo. I think he's amazing. I think it's global health in some ways, because I think he's bringing back like values like empathy, like kindness, and I think that's what we miss in global health, because everything that's happened in the past is because we lost those values. So that's my first kudos. The second kudos is I was at an event hosted by the Gates Foundation in Kenya. Right now, it's a little bit controversial to be at an event hosted by the Gates Foundation, but it was an event with the grantees of the Gates Foundation, of which we are one, and there were about 300 organizations in the room. And then there were these spotlights of some of the grantees that they are funding. And there was one gentleman who took, I think, his sister-in-law to a labor suit to have a baby. And the sister-in-law got PPH, which is postpartum hemorrhage. And during that experience, he observed certain things, during that experience. And one of the things he observed was this new technology, very low-cost technology, around how PPH has been managed over the last couple of years that is actually saving women's lives. And it's a drip that is put and used, and then this drip sort of traps the blood. And depending on how much blood has been trapped, healthcare workers know exactly what to do. So it's calibrated. If the blood is here, you do X. If it's here, you do X. Very simple, low-cost technology that is saving lives. So this gentleman observed this, and then he got curious. And once he learned what this could do, he said, I'm going to manufacture as many drips as possible and to save as many lives as possible. So he started a small, fabrication outfit and started manufacturing drips from a small little shack. And now the guy is manufacturing millions of drips and exporting them to within Africa, outside Africa. And I was just fascinated. And the company is called, I need to get it right, it's called Njembuma, okay. Which means something very specific. But I was really blown away that somebody took this life-changing experience, personal experience, and turned into something which is just amazing. So kudos to the Njembuma team based in Kenya. And kudos to Poplio. That's my kudos for the week.
Okay, so Catherine, I'm going to say maybe it's because we mentioned the Pope in the last episode we had. All comes down to inside track, right? It's all the influence that we have on the global discourse, including at that kind of level. Ricardo, what's your kudos today?
So my kudos, actually, I was at the Skoll World Forum last week in Oxford, which is one of my favorite conferences annually to go to. People are just extremely kind to each other. In the time and age, I must say that that's a rarity. And to feel that kind of spirit and ecosystem felt good. So, of course, kudos to the Skoll team. But I want to highlight in particular, and that's my choice for this episode, is to actually one of the awardees. So at the Skoll Forum every year, there's a Skoll Award for Social Innovation. One of the awardees here this year in 2026 was the Child Life Foundation, based out of Pakistan. And basically, the premise was that Pakistan faces one of the highest child mortality rates in the world, with nearly 1,000 children dying every day from treatable conditions like pneumonia. And what the Child Life Foundation did was to start to work towards preventing those deaths by strengthening Pakistan's struggling pediatric emergency care system, working with governments to rehabilitate and manage their pediatric emergency rooms, with building up their public hospitals to have really world-class facilities capable of responding to needs. And because of their work, they've actually been able to achieve a 10-fold reduction in child mortality in emergency rooms that Child Life manages. And that, I think, alone is extraordinary. Now they're building governmental doctors' capacity and scaling the number of ERs that they are investing in. They're also investing a lot in telemedicine sites. They already have more than 400 telemedicine sites. And the organization is hoping to deliver life-saving care to 20 million children each year. So a good team with a good vision and with a lot of drive can save lives. And I think that deserves the kudos this week.
Great. Thanks for that. Kudos. And mine is actually related to something Catherine talked about in terms of what we've learned about through COVID and things like Gavi and others doing things differently. In April, it's the World Immunization Week, and there were some numbers about how the sort of big catch-up that was a 2-3 year program that they put together to actually cover children who were not vaccinated, partly because of the time of COVID, etc., and about 36 countries in Africa and Asia, and they really got some good results in the last 3 years, getting those children, including those with 0 dose of any kind of vaccine, actually. And that was actually quite interesting to see. So kudos to this big catch-up campaign done at these 36 countries, and about 100 million vaccine doses were really delivered for life-saving diseases. And they didn't look just for under ones. I think they went up to 5 years old to kind of not miss anyone. So that's my kudos for today. So if we want, we can. So that's yet another lesson. So I think this brings us to the end of today's Inside Track. Again, thank you, Catherine and Ricardo, and we'll see you next time.
See you then.
Thank you. Bye-bye.
Bye.
Bye-bye.
To learn more about the topic discussed in this episode, visit the episode's webpage, where you will find additional readings, show notes, and translations. Don't forget to get in touch with us via social media, email, or by sharing a voice message. And be sure to subscribe or follow us wherever you get your podcasts. Global Health Matters is produced by TDR. a United Nations co-sponsored research program based at the World Health Organization. Thank you for listening.